Hello, welcome to the National Government Services YouTube video on Principal Illness Navigation. In 2024, CMS finalized some coding and payment changes to better account for resources involved in furnishing patient-centered care that involves a multidisciplinary team of clinical staff and other auxiliary personnel. These finalized services aligned with Health and Human Services Social Determinants of Health Action Plan and helped implement the Biden-Harris Cancer Moonshot goal for every American with cancer to have access to covered patient navigation services. Specifically in 2024, CMS finalized to pay separately for community health integration, social determinants of health risk assessment, and principal illness navigation. Community health integration and principal illness navigation services both involve person-centered assessment to understand the patient's life story, care coordination, contextualizing health education, building patient self-advocacy skills, health system integration, facilitating behavioral change, providing social and emotional support, and facilitating access to community-based social services to address unmet social determinant of health needs that the patient may have. So today in this video, we're going to talk specifically about principal illness navigation. Principal illness navigation are services that are designed to help patients and their families navigate serious, high-risk conditions, illnesses, or diseases. So principal illness navigation would follow an initiating E&M visit that addresses that condition. CMS has defined this condition or this situation as one serious high-risk condition that is expected to last at least 3 months and that places the patient at significant risk of hospitalization, nursing home placement, acute exacerbation or decompensation, functional decline, or death. The condition requires development, monitoring, or revision of a disease-specific care plan and may require frequent adjustment in the medication or treatment regimen or substantial assistance from a caregiver. Now, some examples of high-risk disease that we're talking about would be cancer, COPD, congestive heart failure, HIV or AIDS, some severe mental illnesses, and substance abuse or substance use disorder. So this is not an all-inclusive list, but this is just an idea of what we're discussing with this service. As always, clinical judgment should be used in determining that case. So I mentioned that principal illness navigation starts with an initiating E&M visit. That visit is required prior to commencing the principal illness navigation services. It is also required annually for that visit to determine the ongoing level of care or need involved for the patient. The initiating visit may be the E&M visit that's furnished as part of transitional care management or TCM. So it could be the same visit that's involved there. It is a visit that is other than a low-level E&M, so it should not be a level 1 or 2 E&M service. It's going to require some medical decision-making, and as we mentioned, it's a serious condition that's being treated. It can also be an annual wellness visit by the billing practitioner for that initiating visit. So the practitioner establishes an appropriate treatment plan during that initiating visit. Now, some things to keep in mind: inpatient observation visits, ED visits, SNF visits, those would not typically serve as a principal illness navigation initiating visit. Now, CPT code 90791 for psychiatric diagnostic evaluation and also the health behavior assessment intervention services may be used as an initiating visit. CMS added this specifically into the benefit because these are services provided by clinical psychologists. It is the most comparable codes to E&M codes that are utilized by the clinical psychologists. And clinical psychologists do have an incident to benefit. They do fall into the parameters of providing principal illness navigation because of the incident to piece of that. So the initial visit that we've discussed must identify that one serious high-risk condition that is expected to last at least 3 months. You need to indicate the significant risk of hospitalization, the nursing home placement as acute exacerbation or decompensation. Whatever's going on with the patient, all of that must be documented. The condition requiring developed monitoring or revision of a disease-specific care plan and may require frequent adjustment in the medication or the treatment regimen or substantial assistance from a caregiver. All of that would be documented. All of those provisions would be documented and what is being looked for in the principal illness navigation services. Now, subsequent PIN visits are going to involve auxiliary personnel that are providing services incident to the practitioner who billed the PIN initiating visit. So those services may be provided by the auxiliary personnel that's under a contract with a third party. It does not have to necessarily be auxiliary personnel of that physician. If they do have to have some kind of contractual agreement or obligation to meet the incident to guidelines. But that is acceptable and that will be fine for this benefit. Auxiliary personnel must be certified and trained and be authorized to perform under state law and regulation whatever services they are providing. Now, another piece is the peer support specialist. If there is no applicable state requirements that exist for a peer support specialist, training must be consistent with the national model standards for peer support certification that have been published by SAMHSA. So what is a PIN peer support specialist? If you've not heard of that, this slide kind of gives you an overview of what that is. It must be a person who is in recovery from mental illness or substance abuse disorders, and they are supervised by a mental health professional, and they complete training that provides a basic set of competencies necessary to perform the peer support function. This would include demonstrating the ability to support the recovery of others from mental illness and or the substance use disorders and ongoing continual education requirements for them to perform those functions. Okay, principal illness navigation. Now we'll talk about billing and we'll talk about the coding of these services. And there's two different sets of codes, G0023 and 24. Are for PIN services that are provided by certified or trained auxiliary personnel. G0140 and 46 are for those PIN peer support services that are performed by certified or trained auxiliary personnel under the direction of a physician or other practitioner. Okay, so G0023 in most scenarios, G0140 and 46 with a peer support specialist involved. You'll see for both sets of claims, there is a 60-minute base code and then a 30-minute, additional 30-minute add-on code for additional time that is provided. And all of these are per calendar month. Okay, so medical documentation. You'll notice some information regarding beneficiaries' verbal or written consent. As with other services, you do have to have patient consent documented. The activities that are performed by the auxiliary personnel and how they relate to the treatment plan are going to be documented as well. So what are they doing, why they are doing it, and how it ties back in. Now, it's not a requirement, but CMS does encourage practitioners to record the associated ICD-10 code in the medical record and on the claim. We are talking about services that are related to social determinants of health, so having that would be a benefit. Time spent performing the different services is going to be indicated within the documentation, and a key here is that time performing two different services may never be double counted. So make sure you're documenting that appropriately. And as I mentioned, if social determinant of health is applicable, include that in the documentation as well. Now, CMS does not have frequency or duration limits to the services at this time. Utilization will be monitored, and CMS will reserve the right to come back and alter that in the future. You cannot report principal illness navigation and principal illness navigation peer support services concurrently for the same serious high-risk condition. A key note here is that PIN services are per condition. So rather than the patient only being able to have one PIN service at a time, this crossover in navigation is unnecessary, as a patient receiving PIN for one condition that gets diagnosed with cancer would likely qualify for a second oncology-specific PIN navigation. So a lot of comments came in when CMS was considering this benefit for the 2024 timeframe. After reviewing much of the public comments, they decided to finalize a required number of hours of training for auxiliary personnel to provide PIN services would be deferred to state requirements where applicable for all auxiliary personnel. So services are performed under general supervision. As I mentioned, the Incident 2 criteria applies here for this service. And also direct contact is required, whether in person or audio. You do have to have that direct patient contact of some type for the patient. Okay, and our next discussion point is community-based organizations. These are community health workers, care navigators, peer support specialists, and other such auxiliary personnel may be employed by community-based organizations as long as there is the required supervision by the billing practitioner for these services, similar to other care management services. So, as I mentioned, this can be a contract management situation where the practitioner reaches out to the community-based organization to have that working relationship with these folks. So as long as the required supervision by the billing practitioner for these services, similar to other care management services, exist, that is an acceptable method to use staff for principal illness navigation. Okay, that is our discussion of principal illness navigation for this session. I want to thank everyone for your time. Thank you for your consideration today. Hopefully you found this information useful. And please be sure to check out our other YouTube videos that we have on various topics as well on the NGS Medicare YouTube page. Thank you again for joining us. We will talk again soon, and have a good day.